Good afternoon, everybody. My name is Victoria, and I have the privilege to welcome everybody to today's MCRH and MSU COM Infectious Disease Echo. Our topic today is HIV Guidelines for Primary Care Providers. Just a couple of housekeeping announcements. For a more collegial environment, we will use first names only. Please be conscious of confidential and protected health information. If you have a question, please raise your hand if you have a desire to speak. Or you can just unmute yourself and just say, I have a question, or put it into the chat box. Presentation will be available to everyone following today via email. The value of the echo is in case studies, so please volunteer a case. Our case form is found on the MCRH website. Introductions, I'll ask everyone on today's echo to rename your echo screen to show your first and last name, and then by right-clicking on the circle or your picture, and then renaming your screening if you haven't already done so. First, then we're going to go down the list and do introductions of who's on the call. You can just say your name and then where you're located or where you work. I'll go ahead and start. My name is Victoria, and I work for Michigan Center for Rural Health, and I will be helping to facilitate today's program. The next person I have on my list is Peter.
Yeah, this is Peter. I'm the speaker for today to talk a little didactics about the guidelines, and I'm from Michigan State University in East Lansing.
The next person I have is Christine.
This is Christine Koga. I do infection control for Deckerville Community Hospital.
Thank you. The next person I have is Lindsay.
Hi, my name is Lindsay, and I'm an RN substance use care manager at Oconee Health Center in Alpena.
And thank you. The next person I have is Sheila.
Hi, my name is Sheila Wilson, Nursing Supervisor, Public Health, Muskegon County.
The next person I have is Julie or Julia. I don't know if she has speaker. There she is.
Hi, my name is Caitlin. I work with Tuscola County Health Department.
Oh, thank you, Caitlin. And then the next person I have is Julie or Julia.
Julia, I work with Shore Hospital in Pigeon.
And I think that's everybody I have on my list. If somebody else pops on, they can put their name into the chat box and where they're located, and we'll get them next. We'll just recap our last session. Are there any updates, questions, or clarifying or clarifications that arise from our last session? Just as a brief update or reminder, our last session was treating hepatitis C in a rural setting. Or are there any questions or clarifications, any updates from last session's case studies? Okay. And then also, just as a reminder, please consider putting one thing in from the session that you learned or that will influence your practice into the chat box at the end of the session. With that, I would like to introduce our speaker, Peter, who will be speaking on the HIV guidelines for primary care providers. Again, just a reminder, if you have questions that arise, please put your hand up or unmute yourself so you can ask your question, and you can also put them into the chat box. We'll go ahead and get started.
Okay, thank you. So today what I want to do is kind of give everybody a nice overview of HIV for primary care providers and give them some just basic guidelines of where we are today with HIV. Next slide. So I have nothing to report as far as conflicts of interest. Next slide. So the objectives today, I'm going to discuss some basic epidemiology of HIV and who the high-risk individuals are, discuss the stigma associated with HIV, and then to discuss a little bit about the basics of how HIV infects the body and some of the early symptoms of HIV, and then talk about how to test for HIV, and then some of the long-term effects that HIV can have on the body, both treated and untreated. And then finally go over some issues about antiretroviral therapy and how we use that, and then how we perform wellness on patients with HIV, and how primary care providers are so critical to providing care for HIV in 2021. Next slide. So just to begin with the epidemiology of HIV, as you can see, there's about 1.1 million people in the United States that have HIV. There's about 38 million people worldwide with HIV. And about 15% of individuals with HIV are unaware of their HIV status in the United States. And this small group, this 15%, is responsible for over 50% of new infections. So this is why it's very critical to test as many individuals as you can, no matter where you're located. Definitely high-risk individuals, but individuals in general, just because of the fact they may have been high risk and then stop doing the high-risk activities, but may still be infected. So testing is still very important. There's about almost 38,000 newly diagnosed individuals with HIV in 2018. This number has actually gone down a little bit. And the good news is because of PrEP, pre-exposure prophylaxis, which we'll talk about in another session, as well as the fact that if we get an individual with HIV undetectable, if we put them on treatment and their viral load is undetectable, they are basically untransmissible. So that's another important point about HIV. If that patient no longer has a detectable viral load on therapy and maintains that, he cannot transmit that virus to another individual, even if they do unprotected high-risk sex. And this was proven in a study done with over 4,000 patients internationally. As far as the new diagnosis, it's decreased, as I mentioned. And the high-risk group for new cases of HIV are men having sex with men, individuals that are Black/African American, and usually young individuals, ages between, I'd say, 16 and close to 30 years of age. So that is the highest risk group in the United States for new cases of HIV. And fortunately, the death rate for HIV has been declining because of our therapy. Next slide. So one of the major issues about HIV is stigma, and that really fuels HIV, both the lack of getting tested, the lack of going to providers, et cetera. And next slide. And the reason being is that stigma is one of the major barriers to both screening and testing. And many times people living with HIV are hard to believe in 2021, but still there's many medical providers and medical professionals that still don't understand HIV and still look at it as being a highly contagious disease, that patients that got it were doing very serious issues to get the HIV. And the fact is that it can be transmitted like COVID, through the air and things. So they're very, they avoid HIV patients. I've had patients tell me when they go to their primary care provider, the provider many times sits across from them at least, 12 feet away, doesn't come close to them, wears gloves all the time. I mean, they take more protection against HIV than they do against COVID virus. So again, this is not something that is needed to be done. And HIV patients have to be taken, being treated considerately like any patient with a primary care problem. And so because of that, many times patients are less likely to go to their primary care. They feel uneasy with them. They feel the stigma. Many times they don't take their medicine appropriately, not only for HIV, but for other conditions, just because there's not that care and not that close attachment, that many patients need. Because again, many patients with HIV have a severe mental health issue that leads toward depression, withdrawal, PTSD, etc. And this leads toward this issue of stigma. So I think as primary care providers, no matter what level you are, I mean, it's important to understand what HIV is in 2021. And it is a disease that is a chronic disease that is very treatable. And patients with HIV have many underlying problems that I'll get into later on. Next slide. So looking at it as far as a brief overview, HIV stands for human immunodeficiency virus. It's an RNA virus that is classified under the category of retroviridae or retrovirus. It's a virus that needs to live in human cells like all viruses do, but the cells that it uses are basically T cells. And the main body fluids that can transmit HIV are semen, blood, vaginal fluids, and breast milk. So it's not in the saliva, it's not in urine, it's not in stool, it's not on the skin or anything like that. Unless there happens to be blood associated with it. So those are the main areas of dissemination. Next slide. And so what HIV does is it basically weakens the body's immune system. It attacks the CD4 cells specifically. And once these cells are destroyed, there's an ongoing problem with your immune system, one arm of the immune system, that then over time can lead to serious infections. And many times HIV untreated can remain chronic for 6 to 8 to 10 years, but eventually all patients with HIV end up getting acquired immunodeficiency syndrome, AIDS, which is the terminal part of HIV. Once you get AIDS, usually your survival is between 1 and 2 years. Next slide. So what about the transmission? And again, individuals that have high risk of contracting HIVs, and these are all individuals that should be definitely considered for testing, are MSMs, men having sex with men, individuals that have multiple sex partners, individuals that are substance abusers, individuals that have needles that they share, either for tattooing, for piercing, not using sterile equipment, but, sharing needles, sex partners of people that are with high risk behavior. So a relationship between two individuals, the one individual may be very safe and be very careful, but the other individual is high risk, multiple partners, et cetera. That individual still has high risk effects of contracting HIV. Mother to fetal transmission. This has been one area that's been very well controlled. In the past, a mother who was positive for HIV had over 25% risk of transmitting it to the baby untreated, just in general. With effective treatment for HIV and total suppression of the virus, that mother has less than 1% chance of transmitting HIV to the baby, less than 1%, meaning that all women with HIV can very effectively have children that are HIV negative if they just use HIV medicine to keep themselves undetectable. So this has been a huge breakthrough with HIV over the years. Breastfeeding, again, is really to be, discouraged. I know in developing countries where, using other forms of trying to feed the baby is met with a lot of side effects, and breastfeeding is done there. In the United States, it's still discouraged since there is a small risk of it being transmitted through breast milk. And then pre-masticated food for patients from parent to child. Next slide. So how do you reduce the risk? Well, safer sex with each encounter, trying to avoid, using prevention. Obviously, we have the pre-exposure prophylaxis method of putting anybody that has high risk of contracting or exposure to HIV, putting them on an HIV drug, either Truvada or Descovy, so that they can prevent HIV from entering their body should they be exposed. This is something we'll talk about in another episode of ECHO. Using clean needles and equipment. So needle exchange programs are very critical in areas not only to prevent other conditions like hepatitis C, but also HIV as well. And this is why the transmission of HIV through needles has actually gone down a lot in the country, and including in Michigan as well. Testing all pregnant women. There is no individual, if they're pregnant, they should be tested. Trying to look at a person and say, well, I think you're probably high risk. You're not a high risk, can be met with failure. And there's been several episodes of women contracting or delivering an infected baby because nobody bothered to test the mother. And this should never be done. Having babies positive with HIV is really very devastating. And actually, the last 3 individuals that I had die from AIDS were young individuals that had HIV were born with it, and then had to take medicine and to do blood work throughout their entire, young childhood. And then when they got to be teenagers, and I took care of them because I only take care of patients usually 17 and above, they started to fight the disease. They didn't want to take pills anymore. They didn't want to take tests anymore. So they just became rebels and stopped their medicine. And unfortunately, they acquired AIDS and passed away at ages 20 to 25. So this should never happen. All pregnant women should always be tested. Avoid breastfeeding, as we talked about. And then treatment as prevention, getting individuals on HIV treatment. Undetectable viral load means untransmissible. This is one of the most effective ways to prevent HIV transmission. And then the final way is PrEP, pre-exposure prophylaxis. Next slide. So getting into some of the presentations of HIV, and what I want the primary care providers to understand is the earliest presentation of a person that gets recently infected with HIV is a condition called acute HIV infection or acute HIV syndrome. It usually occurs within 11 to 12 days after exposure to HIV. And usually there's a high risk condition that occurs prior to that. For instance, patients going in for an STD, say gonorrhea, chlamydia, syphilis, and then 10 days later coming down with this condition, acute retroviral syndrome, which I'll talk about, is very common, or IV drug users using an unsterile needle and then coming down with this syndrome. So usually a high risk exposure within a week and a half to 2 weeks of this syndrome is a critical part of the history of this. And usually during this acute infection is when patients are most infectious to transmit that virus. Their viral loads many times are in the millions, and that's extremely high. So any type of sexual activity, be it genital vaginal, genital anal, or even oral, has a high risk of transmission of HIV during that period of time. And then 50% of individuals who get this acute syndrome do feel ill during this acute syndrome. Next slide. So what are the symptoms? Well, the symptoms are very nonspecific. They're like an acute mono-like illness: fever, headache, fatigue, sometimes a nonspecific macular rash on the trunk and extremities, not on the palms and soles like syphilis, but on the trunk and extremities, sometimes somewhat of a pruritic rash. They get a severe sore throat. Many times they're screened for strep or mono, and they're negative. They have diffuse adenopathy, axillary, cervical, that are usually tender and palpable. And then some of them may even have diarrhea with this. The conditions may be mild, moderate, or severe, but many of them are severe where they are many times bound in the home for a couple days to a week or so because they can't eat or drink. And many of them go to the hospital because they're dehydrated. And this is where many of them are not even considered for HIV at that point. Sometimes they come in with meningitis, aseptic meningitis, or Guillain-Barré can even occur rarely during this period of time. But this is where they can become very, very infectious, and occasionally their immune systems can be damaged very severely during this acute bout. Next slide, please. So how do you, with this condition here, what is the testing that is frequently done for people that are suspected of having HIV? And so there's the rapid testing that's done. Basically, these are tests for antibodies. They can be done in a very short period of time. They can be done in offices, STD clinics, etc. And you can get your answer back, within a half hour. The problem with this test is it's a good screening test, but it may miss somebody with early disease like the acute retroviral syndrome, because many times during those symptoms that I explained to you, the patient hasn't developed enough antibodies to be detected on this test. So if you suspect somebody with acute retroviral syndrome and that rapid test comes negative, don't say, oh, you're probably negative for HIV, so let's look for another diagnosis. No. Go further. So how do we go further? Well, there's a test that is a more verifying test. And even if you did do a rapid test on anybody and it was positive, you would verify it with a 4th generation test. This is the test that's done the most frequently in testing for HIV. And it basically involves both testing for an antigen called a P24 antigen and an antibody. That's the first layer of testing. If that becomes positive, then the next test is an HIV 1 or 2 test that's much more specific, and it cements the diagnosis. With the rapid test, sometimes somebody may be positive for 3 weeks or beyond before the test will become positive. With the 4th generation test, it can detect somebody up to 2 weeks after exposure. So a much more sensitive test to shorten that window period. Somebody, and I just had this happen about 2 weeks ago, where I had a case come in, high risk for exposure, had symptoms, and yet the rapid test was negative. They did a 4th generation, and the first part of it, the antigen antibody, was reactive, but the second part was indeterminate. So what else can you do to better diagnose the acute retroviral syndrome? There's another test that's not listed here called the viral load. We usually use the viral load to test for how effective the therapy is, but it is a test that checks just specifically for virus antigen. And it's sensitive up to 10 days, 8 to 10 days after virus. So it's the most sensitive test we have. And this test can be used many times to diagnose that syndrome. So always kind of remember those different tests that I described. The majority of individuals that don't have acute retroviral syndrome, the 4th generation can easily diagnose it. But in those cases where you suspect somebody just recently diagnosed and you have the testing that I mentioned, use that viral load as being the more definitive test. Next slide. The CDC recommends testing all individuals 13 to 64, and actually it's extended the age up to in the 70s now. Screen individuals at high risk more than once. You have an IV drug user, you have somebody that does sexual activity, high risk sex activity, and you've screened them and they're negative. If they continue that high risk sex activity and they're not using any other prevention, test them every 3 months, 6 months. Don't just assume that one test is all you need. And then screen all pregnant women, as I mentioned. You don't need a separate signed consent. All you need is what's called opt-out. Can I test you for HIV? Yes, you can. Test them. No, I don't want to test. Then you obviously can't test them, but you don't need a signed consent as was done years ago. Next slide. So how does HIV affect the body? Well, basically it depletes the body's immune system of T cells. And once T cells are destroyed, it's a slow process, but then conditions can occur through that destruction of T cells. It can evolve over sometimes years, but patients can get nonspecific symptoms of diarrhea, rashes, severe bouts of Candida, different things like that. And then as it goes deeper and deeper and more decline, then you can get opportunistic infections. but it definitely affects the body. It definitely affects different parts of the system, the organ system, the peripheral nerves, and then chronic inflammation, which, as you recall, with the COVID, you've heard the condition cytokine storm, and those cytokines are just rabid, and that's what causes all the symptoms and destruction of the body, and then eventually kills you. Well, chronic inflammation is a minor bout of the cytokine storm. It's where the cytokines are still active, but at a much lower level. So they can still cause damage to your cardiovascular system, to other areas, but not at a high degree. And this is what causes much of the morbidity, mortality in HIV. It's not opportunistic infections. It's dying from heart disease, from malignancies, from renal disease. And a lot of this is perpetuated by chronic inflammation. Next slide. So once acquired, HIV is a lifelong condition. It's there for forever. It's a chronic disease. There's no cure. It's not like hepatitis C. It's not like, COVID virus, but it can be controlled with daily medications. And here's the important point I want you to remember. The life expectancy of an HIV patient now on treatment, where their T cells are normal, 500, is the same as somebody HIV negative. I mean, give or take 1 or 2 years because of chronic inflammation, but it's almost the same. So patients with HIV have normal lifespans now. They can live a normal life with good quality. They can have a family, they can have kids, et cetera, and not have to worry about dying early. Without treatment, however, patients with HIV will go on to develop AIDS. Next slide. So what are the blood tests I do to monitor patients with HIV? Basically, I do T cell counts. And as long as they're normal, that's what's most important, because then they're at very low risk for AIDS or complications. And then I do a viral load, which tells me if the virus is under control on their medication. And so this is something I measure usually every 3 months. And I do the T cells. If they're normal, I'll do it every 6 months or so. So these are the two main tests we do for HIV measurement. Next slide. The criteria for AIDS is if the T cells drop below 200, even if they're not with an opportunistic infection, just that count below 200 puts them at a category of AIDS. And when they get to that category, they have to be on prophylaxis, usually for pneumocystis. And then if they have other opportunistic infection risk for those as well. But you can see that there's a list of different infections that they can acquire when their condition is below 200. We rarely see that now because of these effective therapies we have. The ones we see with AIDS are usually newly diagnosed if they haven't come in early, or ones that stop taking their medicine and are lost to care and come in with AIDS. But this is a condition that we rarely see, and we can always get them out of AIDS. They can come in with T cells as 0. And I've had patients after 6 months of therapy where their T cells are in close to normal, if not normal, with undetectable viral loads. So it is a totally reversible condition in many respects. Next slide. This gives you a long-term story about HIV, where it's a disease that can go on for years, and you can see how it slowly declines the T cell count because of the ongoing viral load. And this is what we had to deal with prior to therapy. And usually we started getting symptoms when the T cells got down to below 400 in the 300s, and then below 200 documented just having AIDS. We can reverse it though. We can reverse that line going straight down to going up again to where they're asymptomatic and quality of life is good. Next slide. And this just gives you an overview. I don't want to spend a lot of time on this, but it's a nice slide just to show you some of the different opportunistic infections and what parts of the body they hit. But basically, fortunately, unlike the 80s where I saw, this is all the only thing I saw with HIV. I didn't have therapy, so I had to treat opportunistic infections, and I saw every one of these. Now we rarely see those because of the therapy we have. Next slide. So treatment and wellness, care for the person with HIV. Next slide. This is where providers, primary care providers, are the major focus of HIV care now. It's not me. My job is simple. I give them a drug, 1 pill once a day, get their T cells normal, viral load suppressed. That's it. But what they really need is they need ongoing care for all their other conditions as well. So when a person first comes in with HIV, we educate them about HIV, how the disease progresses, how it's transmitted, And then we talk about how important treatment is, not only to keep them healthy, but to prevent them from transmitting the disease. We talk to them about safe sex and risk reduction. We talk to them the fact that even if they are suppressed, they can still get other STDs, syphilis, gonorrhea, chlamydia. They can even get reinfected with HIV if they get a resistant strain. And then we talk about their chronic health conditions. This is probably most critical. You know, the majority of people with HIV have severe mental health and substance abuse problems. So unless those are controlled, you've won a battle, but you've lost the war. Those are ones that don't take their medicines. They don't come in for visits, and many times they'll come in with end-stage AIDS because of that. And then you start the treatment as soon as possible. We don't delay treatment like we used to until a T cell count got to a certain level. Everybody that's HIV positive gets on therapy as soon as possible. Next slide. And these are the tests that we order. We talked about the CD4 viral load. We do a genotype to measure to make sure the virus doesn't have any resistance to it. And then we do a variety of other blood work, including hepatitis checking. And if they're negative for Hep A and B, we vaccinate. We check them for STDs, and TB testing is done as well. And there's other tests we do as well, but this is just a general group of tests that we do. Next slide. And then we we give them highly active antiretroviral therapy. We make sure that they understand that they have to take the drug forever. It's a one pill, it's daily. Chronic disease, like you take your insulin every day, you take your pill for HIV every day. And this will keep your T cell count normal and prevent you from transmitting the disease and then prevent you from getting those opportunistic infections. Next slide. So who should be on antiretrovirals? Everybody. The Department of Human Health Services has recommended that everybody should be on retroviral therapy because of the fact that it will prevent morbidity, mortality, plus it will prevent HIV transmission to others. U equals U. And it should be started immediately. Why is that? Because the longer you delay treatment, the patients kind of realize, well, maybe this isn't such a big deal. And you know, because of their stigma, they tend to stop coming to visits, they miss appointments, and they get lost to follow-up. When you put them on immediately, you get that virus under control immediately. You tell them, this is a thing we need to get under control. It's like a blood sugar of 500. You're not going to wait for a month till you treat them. You're going to get them under control quickly. So same thing with HIV. So we get them treatment. That links them to care better, keeps them in care, and keeps them suppressed. Next slide. So what is highly active antiretroviral therapy? That's HAART. It was first discovered, AZT was discovered in 87, but actual HAART medication that actually improved the prognosis of patients was in 1996. It was basically taking 10 to 12 to 15 pills 3 to 4 times a day. It was hard. There was a lot of toxicity with it. Many patients got discouraged and stopped taking their medication because of the fact that the therapy was so toxic and it made them feel sick. But now with new therapy, it's much better. And this is what we're trying to accomplish. Next slide. And these are just a good example of how many are there? 10 therapies that are single tablet. Each one of these is a complete regimen for HIV. They have 3 pills in 1 tablet. And actually there's another one out there, Jaluca being one, and Dovato, which is actually only 2 medicines, which we can treat now HIV in 1 pill. So it's very simple to treat HIV patients. 1 pill once a day. It's just like Hep C, except HIV is a lifelong treatment. Next slide. And so a couple months ago, the FDA just approved a new form of treatment. It's actually our first way of treating with injectables. And the injectables are 2 drugs, carbotekravir, which is a integrase inhibitor, and rilpivirine, which is a non-nuke. They're injections now, no pills anymore. You come in once a month, get your injection, and that's it. And what I can tell you is this combination is going to soon go to every 2 months treatment within the next year. So a patient no longer has to take any pills, just come in for their injection. And I can tell you within the next year to 2, there's another company that's got an injectable that's every 6 months, twice a year coming in for your treatment for HIV. There should be no reason as far as adherence that patients can't do that now because there's no pills involved. It's just coming in for an injection. And for PrEP, which I'll talk about in another thing with Echo, there's the same regimen, well, not same regimen, but it's cabotegravir will be given once every 2 months instead of having to take Truvada or Descovy every day for PrEP, for pre-exposure. You can come in once every 2 months, get a shot, and that's your prevention. And they've shown that to be superior to taking the pills as far as preventing new cases. So this is a new era of HIV going into injections now. Next slide. This is where the primary care is very important. This is where they take the ball and run with it. They take care of all the other aspects of HIV care, and they can take care of HIV as well if they feel comfortable enough. But this is where, making sure the nutrition is adequate, making sure patients' immunizations are up to date, making sure that they get screening for different disease states like tuberculosis, for instance. Many of them are substance abusers, making sure that they're on alcohol preventative programs or substance abuse programs, because this is what leads to non-adherence and recurrent HIV disease. If they have lipid problems, then they have to be assessed for that, because two of the most common conditions now that are causing deaths in HIV patients are not pneumocystis pneumonia and cryptococcal meningitis, is heart disease and malignancies. So they have to be screened for malignancies and screened for heart disease as well. Making sure that they don't get other STDs, because STDs are on the rise now. And these heart regimens don't prevent STDs. So syphilis in my community in Ingham County is third. We're third in the state of Michigan for syphilis outbreaks in Ingham County. And down in Detroit, there are several communities are number 1 and 2 for chlamydia and gonorrhea. So they're on the increase. And then screening for hepatitis, including C, and then for other conditions like osteoporosis. This is where the primary care provider is extremely important. And in all my practices in Michigan, I take care of the HIV, but I always have a primary care that does all the wellness care as well, because their focus and their position in HIV care is more important than mine is actually. Next slide. So next slide. And this is where the examples of other illnesses. Many of them have diabetes, hypertension, hyperlipidemia, heart disease. Many of them have had a stroke. So these are all areas where they have to be monitored for. You can't, treat a CD4 and viral load and ignore a blood sugar or a blood pressure of 200/120 or a cholesterol of 300 and triglycerides of 500. This is what's going to kill the HIV patient, not the viral load and T cell count at this point. So this is where the primary care is extremely important in taking care of the HIV patients and monitoring for these conditions. Next slide. And psychiatric illnesses, 2 of the major issues with HIV patients, because many HIV patients are born in horrible environments. They're born in abusive environments. They're used as sex slaves. I had a case not long ago where the father was selling his 14-year-old son as a sex slave for sexual activity, and all this abuse and physical abuse, mental abuse as young kids, and just treating them horribly. And many of them got on drugs because of that. So they're drug abusers as well as PTSD and mental health. So majority of them have all these mental health issues that need to be under control. And unless we control their mental health issues, the battle is won, the war is lost. And I lose many of these patients because they just get so overwhelmed with their mental health, they just forget about HIV care anymore. And many of them succumb to AIDS because of this. So these are conditions that really need a very careful care for. Next slide. So any questions? A lot of material there, but I wanted to give everybody a real good update on the current area of HIV and how it's so important for primary care to get involved in their HIV care, not only in testing, but in taking care of them as well.
We'll open the lines for questions and comments about the didactic presentation that Peter went through with us. It was lots of good information. Before we get started with our cases. Okay. Are there any questions, comments, or anything that needs to be clarified? Okay. And then if nobody has any cases that they would like to present, Peter again has agreed to present a case for us. So I will. Sorry, I'm working up on a couple monitors here. We'll go ahead and start our first case.
Yeah, now this case will cement a lot of stuff that we just talked about. So both cases where I hope we can get to both of them, but this is a 24-year-old comes in complaining of a 3-day history of a progressive ache and pain, severe fatigue, and fevers of 101, 102, 3-day history. He's also noted that he's got nodes all over his neck, and his axillary areas, and they're tender nodes. His past medical history is he was just treated for syphilis 3 weeks ago with penicillin. Now start to put this pieces of this puzzle together as we're talking more. He admits to being an MSM and having sex with men and has frequent sexual partners. And he doesn't, and what's not here is he really doesn't use barrier protection at all either. And he's not on any kind of PrEP. So he has frequent sexual partners, and he usually is what they call a receptive anal. He does receptive anal sex where he would be considered the bottom, which is one of the highest risks for HIV being contracted. On exam, he has palpable bilateral nodes in his neck, and he has some white patches on his tongue. Now, what would that be? Think about this a little bit, and we'll get into that in a second here. His labs show that his platelets are down. Normal should be 150, he's 130,000. His white count is 2,500, which is low. Normal should be 4,000. And he's got lymphopenia. A rapid HIV test is negative. So if you've been listening to the talk, you kind of get a description of where we're going with this. This patient, what other tests would you want? Well, he's a young guy. He's got all these aches and pains. It looks almost like some kind of a viral syndrome, but what virus is it? Many times this patient is tested for mono and it's negative. Many times because of the sore throat, they're tested for strep, it's negative. So what else could it be? Well, now you have to look at other facets besides just his symptoms. You have to look at his high risk activities, and he's definitely at high risk. He fits the protocol for being infected. The same time he was infected with syphilis, he was infected with HIV too. And now he's exhibiting the acute retroviral syndrome, and the labs go along with that. Many times with acute retroviral syndrome, the T cells drop because they're consumed by the HIV virus. The white count goes down somewhat because of the lymphopenia, and the platelets go down because of this chronic ITP, where the platelets are being destroyed by the HIV virus itself. So this is a very, presentation. And what did I say early with the acute retroviral syndrome? You do an HIV test, it's negative. That's because the window period is still long for the antibody test. And so this test would probably in many cases be negative, but that shouldn't dissuade you. So what other tests would you want? Well, many of you would probably want to get the 4th generation test, which is fine. That's a good test as well. And in many cases, what the 4th generation will or may show is that first level where test for the antigen antibody, it may show reactive, but then when you go to do the more definitive test, it still may be negative because it's still an antibody test. So now what do you do? Are you still feeling, well, it's still probably negative, so I'll just leave it alone, tell him to go home, get some rest, and he'll be fine? No, you want it to go one step further, and that's doing the viral load. That's where you'll get the diagnosis. So in anybody that you suspect having the acute retroviral syndrome, and this is the kind of the classic case for it, you want to get the viral load to definitely rule it in or rule it out. If the viral load's negative, then you've pretty much ruled it out. If the viral load's positive, you've got the diagnosis. And I'm seeing more and more ERs and primary care doctors utilize this because I'm getting more cases of this. And this is something where you want to diagnose it early for 2 reasons. One is you want to get them on therapy, because the earlier you get them on therapy, the less that virus is going to disseminate throughout their body and find all these little areas to hide. Number 2, it's going to prevent them from reinfecting other people because their viral loads, the last one I saw had a viral load of 2 million. So he is highly infectious. So it wouldn't take but one exposure to expose somebody else to HIV and probably get them infected as well. So This is why I wanted this case presented, because I think it really gives you a good example of what the acute retroviral syndrome is and how it presents itself. Questions or comments on this?
So I just wanted to review the case real quick with everybody. We had a 24-year-old that comes in complaining of aches, pain, severe fatigue, and a fever. We can all read what his signs and symptoms are. The adenopathy in the neck and axillary is tender. He has a history of syphilis 3 weeks ago, was treated with penicillin. He has sex with men, frequent sex partners, and palpable nodes in his neck, white patches on his tongue. His CBC platelets were 1,300, white blood cell count was 2,500 with lymphopenia, and his rapid HIV test is negative. What other tests would you want? We would do a 4th generation HIV test, and then if that came back negative, we would do a viral load test just to be sure. And then if we wanted to then start him on if that came back in our condition, we would most likely think that he would be HIV positive, and then we would want to get him started on antiviral medications as soon as possible. Correct?
That is totally 100% correct. Yes. And if anybody has any comments, please don't be afraid to ask, because I know a lot of individuals are kind of a little nervous with HIV. They feel maybe it's not in their community, but I can tell you it's everywhere. It's everywhere in some of the communities that have, rural areas where individuals are still doing IV drug use. Just like we're worried about Hep C, we better worry about HIV as well. And the same clinical scenario can occur with HIV, acute retroviral syndrome, in an IV drug user that uses needles. The incubation period may be a little bit slower, narrower, because of the fact that the virus goes directly into the bloodstream, but the symptoms that they exhibit are just the same. So usually you tie this in with a high risk individual with symptoms like this. So please don't ever forget the acute retroviral syndrome and how you diagnose it.
And then I just had a question for myself. Do you have or does if anybody else on the line, do you guys have a specific drug recommendation that you would like to prescribe over the other for antiretroviral treatment, or is that just go individual based on provider base?
Yeah, that's a good question. And somebody where like let's just say the viral load came back positive, but we didn't have any other tests on him. We didn't have and so, but you wanted to get him going right away because he's got a high viral load and et cetera, et cetera. There's probably a couple drugs you could use without having information about what if the virus is resistant or not to this or that or the other and different things like that. And one of the drugs would be a drug called Simtuza, and it's a drug with it's Prozista, Norvir, and Descovy. It's 3 HIV drugs in one pill. That would be one. Another one would be a Biktarvy, where it's Descovy and Bictegravir. And a third drug would be it would be 2 pills actually. It would be Descovy and then dolutegravir. Now, the reason I mentioned those 3 drugs is because they all have what they call high genetic barriers to resistance. The likelihood of that virus being resistant to any one of those 3 is very, 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 very small. And they're very potent regimens, once a day regimens. And so you could get them started right away and be very secure that they're going to do well with one of those 3. So those are probably the 3 that would be used by most providers, HIV providers like myself or individuals that might want to get started right away.
Great, thank you.
You're welcome.
I think we have a few more minutes. If nobody else has any questions or comments or has anything clarifications, I think, Peter, do you have another case for us?
I do. Put another case up.
Okay.
Yes, this one may require a little more time, but I know we have sometimes, right? But I think this is a great case to discuss. It's a 25-year-old recently diagnosed with HIV who comes to you now for further evaluation. He has severe depression, anxiety, has been on Prozac, Xanax, Klonopin. He also has PTSD from prior sexual abuse from his father, his uncle, his nephew. He had been on cocaine and recently entered a drug abuse program and is on methadone. He relates to you that he has had dreams of killing himself. Physical exam is normal. Labs, his T cell count is actually normal. It's 550. Anything above 500 is normal. He's got a high viral load of 110,000. The test for resistance, he has no resistance to the virus at all. That's what genotype is. His blood counts, he's got a little bit of an anemia. His hemoglobin is 10. His platelet count is also low, should be 150,000. And his other test, his liver function test, show that he has liver enzyme elevation. And then his kidney function is normal and his blood sugar's up a little bit. So the reason I presented this case is, what would you do at this time? How would you handle his HIV? Well, to be honest with you, the HIV is probably the simplest thing to manage at this point. I mean, you pick one of those 3 drugs I just told you about, and you could easily treat him for that, and it would easily get that disease under control. His T cells are already normal, so he's not, at a high risk for AIDS or anything. You don't even have to rush into treating him really, but his major areas, are, what issues would create or contribute to non-adherence? Look at his history. Look at how seriously abused he was as a child and how he grew up in an environment like that and how he had severe mental health issues as a result of that many times would have contributed him to go to drugs to try to relieve himself of all the mental PTSD, to get him on something to make him feel better. And that's what happens with a lot of HIV patients. They have incredible mental abuse, or not mental abuse, but mental health situations that really traumatize them. And he's already on 3 different drugs there. And this is what really requires the attention of this patient, his mental health issues, his drug abuse issues, because unless we get those under control, unless we try to manage those properly, he's not going to come back for visits. He's going to maybe not even take his meds. He'll take them for a few days, and then he'll come back later and then he'll be off, because the mental health issues will contribute more to his issues and stuff. And then he'll get back on substance abuse again. So my point of this case was to really give you an idea of how abused many of these patients with HIV are, and how many underlying health issues they have that are not related to HIV, but contributed to him getting HIV. More likely than not, because of him being a sex slave, probably he was exposed to high-risk individuals and got HIV through that mechanism, and then probably got a whole host of stigma related to getting HIV now, all the stigma associated with it. And these patients are extremely hard to take care of. They don't come in for their visits. They don't come in to take their meds anymore. And so those were my questions here, is what other issues may contribute to non-adherence and what other tests may be appropriate here. And his lab tests obviously are abnormal. His hemoglobin low, his platelets low, his liver enzymes up. He may have hepatitis C as well, or B, because of exposure to, needles and those kind of things. But, how comfortable would you feel taking care of his HIV? Well, I'm an HIV treater, and I wouldn't feel comfortable taking care of it just because he's got all these other aspects that I would want under control. Even before I might put him on therapy, I might ask this patient, will you take medicine every day? Will you forget to take your pills? And if he can't give me a good solid answer, I may not put him on right away for HIV, because he may not take the pills and he may get resistant to the virus over time. If he takes it and stops it, takes it, stops it. So I really wanted to get you this case to show you what the true picture of HIV can be in many of these patients we deal with now. Questions on this case?
Just to recap this case for recording, we have a 25-year-old recently diagnosed patient with HIV comes to you for further evaluation. His patient medical history he has severe depression, anxiety. He's been on Prozac, Xanax, Klonopin. He has severe PTSD from prior sexual abuse by his father, uncle, and nephew. He's been on cocaine and recently entered a drug abuse program and is on methadone. He relates to you that he's had dreams of killing himself. His physical exam is normal. His CD4 count is 550, which is normal. His viral load is 110,000. His genotype is wild. His CDC count is 10. His platelets are 94 or 90,000. His SGO is 110. His SGPT is 140. His creatine is 0.9. His BUN is 24, and his glucose is 140. How would you feel about handling his HIV? We've kind of come to the conclusion that maybe not everybody would feel comfortable just because of all of his underlying mental health issues. Maybe we would need to refer him to maybe a mental health professional.
Right.
He might have some other underlying health conditions going on with his other labs. So maybe providing him with some other care, maybe having a conversation with him, talking to him about whether he would take his antiviral medications and that kind of thing. Maybe trying to figure out whether how successful his Prozac, Xanax, and Klonopin, and how he's taking his methadone, like that kind of thing. Like, is he getting his methadone from a clinic? Like, how is he doing that? And is he in an inpatient setting, treatment facility, or is it an outpatient? Maybe that's something, another conversation to have with that patient.
No, you hit the nail on the head with all those comments. You really cemented it even better than I did with care of that mental health, either inpatient or outpatient, and making sure there's no drug interactions with the HIV drugs and those drugs. But yeah, making sure that he's on those, maybe being in a medical assisted treatment program for his IV drug use and everything. Excellent points.
Mhm. Are there any other clear questions, comments, or clarifying questions for Peter, or any other recommendations that anybody might have? Please feel free to unmute yourself or put them into the chat box. Okay. Thank you again, Peter, for presenting the cases. Again, like we always say, the real learning comes from the cases that are presented. So we urge everyone or all of our participants to present a case or submitting a case, and we can help you present it. So please remember, and also please remember, the cases do not have to be challenging. They could be like the first case that we saw. The session evaluation, please remember, if you have time, to please enter into the chat box one thing that you have learned or that will influence your practice, or a key takeaway that you will take away from today's session. Just a couple of announcements. Thank you for attending today's session. Our next session will be August 26th. Our topic is mental health and HIV. We will have two speakers, Peter Gulick and Jed Megan. Again, we urge our volunteers, or we urge participants to volunteer case studies, and the case form is found on the MCRH website. Please email me if you have any questions about that. And we will be sending out the recording and resources from this session within 24 hours. Again, CME is available for all healthcare professionals. Directions will be found in the follow-up email. Thank you, everybody, for joining us, and we hope you found this presentation to be very informative. Thank you.
Thanks again.